follow-up, you need to know that what in the follow-up you still have to measure. You have the two means. You have the clinical means of follow-up, and you have the paraclinical means of follow-up. And in the follow-up, you see follow-up according to the SHRDB algorithm. Follow up the disease, that's neonatal sepsis. Clinically, we have fever and we have signs of systemic inflammatory response syndrome that you have to, if they are going to wear off, they are going to disappear. Now we have paraclinically, after every 48 hours, you ask for CRP and then a full blood count to visualize. Also, you have the cause. For the cause, you can visualize clinically and paraclinically based on the point of focus in the case of late onset neonatal sepsis. Then you have the complication. I've forgotten to tell you that among one complication also of sepsis, you have anemia. Basically, and anemia, depending on the severity of anemia, if it is severe anemia, you have to give transfusion to the child. And when you want to transfuse a child, either you transfuse the child 20 to 30 mils per kilogram of per 24 hours, or you can transfuse the child by using a certain formula of whole blood. Use a formula of whole blood or packed red blood cells. So use whole blood or packed red blood cells. For whole blood, the volume of blood that can be transmitted is 66 mils times the HB deficit. So you measure the HB level of you measure the normal HB level that you want to attain. You subtract minus the HB level of the patient, and then you multiply times the weight of the child. So that is how you calculate for whole blood. If you want to do a whole blood transfusion, it's 60 mils times the HB deficit. HB deficit is the subtraction of the HB level that you want to attain minus the HB of the child times the weight of the child. And then you have to make sure that what the fluid that you give that day should not be greater than the fluid. You have to make sure that the fluid that you give that day should not be given greater than the fluid that is more than the fluid of the day of the patient. Is it clear? So if you have, let's say, 500 mils of blood that you have to give to the child, you will not, and then the fluid rehydration of the child normally in one day is 200 mils. So in the first day, you just give 200 mils, or you give 100 mils, and then you give 100 mils of the glucose of the child with the other electrolytes. And then the second day, you give again another 100 mils until you attain your 500 mils. So you don't give all the blood of the child more than the fluid level, the normal fluid level that the child should be receiving. For the packed red blood cell, it's still the same formula, but you instead change with 3. It's 3 times the HB deficit times the weight. So weight in kilograms. So those are the different elements that you have to evaluate. So those are the different elements that you have to evaluate. Now, the next element that you have to do, I was also speaking about the follow-up of the complication. Anemia, you have to speak about the follow-up. You have to visualize clinical signs of anemia, and paraclinically see the flow glucose is going to have. For the jaundice, you visualize for the CAMA classification daily, and then you do the bilirubin level after 48 hours, and you have all the electrolyte imbalance and all that. To visualize lethargy clinically and paraclinically, you do the blood ionogram. Is it clear? So those are the investigation that you have, the follow-up that you do in the patient neonatal sepsis. Thanks for your kind attention. Don't forget to like and subscribe for SchrDbb. Thank you.